Good evening, one and all. I am thrilled to welcome you all for today's informative webinar on approach to vasculitis. Uh, I am thrilled to welcome Mr. Navanil Dutt, who has done MBBS, FIC, DNB pulmonology. Sir, I am privileged to tell you this that the doctor is served in the front line critical care during COVID pandemic. Dr. Navanil is so passionate about teaching and moderating and conducting seminars since 2022. He was also part of West Bengal Rheumatology Association and very regular to their CMEs and seminars organized across the country. During MBBS, he was part of SAMSA, which is South Asian Medical Student Association from 2017 to 2021. In 2019, Dr. Navani was awarded with the Best Poster Case Presentation at the International Undergraduate Conference 29 JIMPMER Pondicherry. Doctor, we are very privileged to have you here on this session, and I believe and I guarantee to the audience that we're gonna have an awesome session because this sixth time that no one is taking the session. Doctor, I am handing over.
Thank you. Thank you so much. A very good evening to all of you. Being introduced every time feels a little, shy at times. But there's one thing. I'm still a member of the West Bengal Rheumatology Association, and I'm also a member of the Indian Rheumatology Association. So there's something. Why the reason why I'm mentioning about the Rheumatology Association is because of my consistent appearance in their different projects all over the country. I mean, even like for the ones who are not aware, we are going to have a national meet at the IRACON, which is the Indian Rheumatology Association Conference 2025 in the month of October, which is going to be in New Delhi on the 10th, 11th, and the 12th of October. So you can, go to the website of IRACON and get yourself registered. So today's topic actually, approach to vasculitis, is something that comes from the rheumatology domain, which is why I wanted to take this up. And before I would like to start, I would wish you all a very good evening. I would thank you all for joining in. It's been a really difficult week for me altogether. And although this is a very professional platform, but I just want you all to know, because you all are doctors, and that's someone who's really close to me. Someone of my family is really battling with her life and death back in the hospital. So I had to literally finish all my works there and, come back home. And the problem and one of the biggest challenges that we all face in this profession is we don't really know what happens to our family at times. And when they are the ones who are battling with life and death, it becomes really difficult for all of us to manage everything. So I think it's the strength of you all, the fact that you all will be attending, that kind of keeps me motivated and passionate to come here every time and, deliver whatever I can from my end. And before I start this topic, I would be really liking to thank somebody whose name is Dr. Dilip Kumar, and he has been my professor of medicine back in my training days, and he's someone whom I still learn from. So before I would take this up, I'd actually like to say this, that a lot of what I'll be saying, a lot of the way that I've integrated this topic is a direct inspiration from what Dilip sir used to. So Dilip sir, if you're here or not, I really want you to know that you have had a big impact in my life. So coming straight to the topic, we're going to talk about vasculitis. And can I just know one thing from your end, that how many of you have completed your MBBS, or how many of you are you the ones who are still pursuing MBBS? I just want to know that poll, so that it'll be a little easier for me to go down on and cater to all the levels. Can someone write to me in the chat, are you pursuing your undergraduates, or you have passed out your MBBS? Can I have a quick 2-3 minute poll regarding that? Yeah, so MBBS intern, Dr. Srishti. Thank you so much. Hi, Dr. Srishti. Dr. Rahul says from BAMS, welcome. Good evening, Dr. Rahul. I'm so happy to know. Dr. Viresh from Ayurveda, that's nice. So different platforms and different specialties coming in together. BAMS completed Dr. Sahadev, finished your internship. Dr. Jitin. Okay, so fantastic. So I have a good branch of young audience and vibrant audience with me. BAMS PG, fantastic, fantastic. Thank you so much. Okay, so I would tell you something. This approach to this webinar is something that I've kept a little different from what I usually keep in my other webinars. So usually in my other webinars, if you haven't attended my previous webinars, the one thing that I've done is I have not filled up everything. And there's a reason. So with whatever experience I've been having in Mediversal over the last 1 year, for example, one thing that I've noticed is I know there's a huge bulk of audience who really wants to know, wants to learn, and they're really interested. But then, as we know, there are some who are probably feeling a little bored or a little fatigued, and they are like, okay, let's get done with the class quickly. And I don't want it to be a very monologue. I don't want it to be a monologue. I want an active participation. And what I've really realized over the last few webinars that I've taken is the moment I fill in every space of the slide, it's like about getting the slides. But trust me, my dear, trust me, my friends, it's not about the slides. It's about the content that I've put in the slides and the integration of those concepts in the slide. So what I've done deliberately, if you could like move on to the next slide, sir. If someone could share me the next slide. Yes. No, not this. Ifka, I'd shared with you. I'd shared with you another slide. If you see, is Ifka there?
Yes,
Ifka?
yes, I'm here. Allow
Yeah,
me a
Ifka.
moment now.
Yeah. Perfect.
One.
So yeah, before as Ifka does that, what we'll be seeing is I filled some of the boxes. Can you see? So here in this slide, most of the boxes are blank, but the one where I've shared with Ifka is where I have filled most of the boxes. Some boxes are remaining. And what I want you all to do is sit with your pen and paper. If you're traveling, then that's a different thing. Sit with your notes, maybe, where you can quickly type in. The ones who are sitting with the pen and paper, I would really request you to sit with a pen and paper. The boxes which are not filled are the ones that I'll be telling you, and I want you to quickly keep on filling them, and that's how we will learn. So once you write something, that's something which I've felt, this is a part of active learning. When we write something, it actually stays more in our brain, it stays more in our consciousness, and that is exactly what I want to do. I want to make things not a monologue, but an interestingly, I want it to be on both ends. I want a very active participation. And yeah, it's a very small, I mean, it's a big topic, but I've tried concising it in the most shortest way possible, to be honest. But trust me, this 1 or 2 pages slide, it may just look like a 1 or 2 page slide. It is going to give you a total overview of all the vasculitic diseases that we have, including its pathophysiologies, its treatment, and its presentations. So that is something that I wanted to do. So please, I'd be really happy if you all can give me a thumbs up. Does that, I mean, I know I'm making you work a bit on a weekend evening, but can you all give me a thumbs up that you can sit with your pen and paper, and the places which are blank, you'll be filling it all up by yourself. Can I have a thumbs up from all of you? As I said, it's been a really difficult week for me, and it's because of you all that I'm here. Trust me, and I'm so grateful and thankful to you all. I just want you all to participate with me in this webinar, fill up the remaining spaces on your own self. Can I have a thumbs up for that? Can I have a thumbs up from everyone? Come on. The ones, yes. So thank you, Ifka. Thank you. Ifka has been really kind and good. And so if you can see, these are places that I've filled in mostly. The ones that I've not is what I want you all to fill with me when I say it. So can I have a final thumbs up before I begin to everyone who's watching? Dr. Jitin, Dr. Sadev, Dr. Mahalakshmi, Dr. Viresh, Dr. Rahul, Dr. Srishti, everyone who has joined in, the other ones. Can I have a very quick thumbs up? Thank you so much. Thank you so much. Okay, thank you, everyone. So let's begin this. Not able to take your names individually, but trust me, my love is to all of you. My regards to all of you. Let's begin this. Okay. So now, when we talk of vasculitis, what do I predominantly mean? Any itis. When I say appendicitis, cholecystitis, any itis, itis, osteoarthritis, arthritis, every itis means inflammation, right? So whenever I mean a vasculitis, I am predominantly meaning an inflammation in the blood vessel, right? So that is what I mean when I say vasculitis. So vasculitis is nothing but inflammation in the blood vessel. Now, according to the international norms, back in the year 2003, there was this classification which was called the Chapel Hill classification. Under this Chapel Hill classification, we had 3 different varieties of vasculitis. The one being large vessel vasculitis, the other is a medium vessel vasculitis, the other is a small vessel vasculitis. So when I say large vessel vasculitis, what are the predominant vessels that I'm meaning? I'm predominantly meaning the intracranial vessels, the aorta, the different parts of the aorta, the descending aorta, the ascending aorta, the thoracic aorta, everything. All of these large vessels are what I mean under large vessel vasculitis. When I talk of the medium vessels, and when I talk of the small vessels, mainly when I'm talking of the small vessels, I'm mainly meaning the vessels that are supplying these smaller areas, the tips of the digits. Okay, so these are the areas which are supplying the skin, supplying the small parts of the digits, the distal vessels. That is what I predominantly mean by small vessels. And the medium vessels is something which is coming in between them. Inflammation of all these 3 types is what can lead to a rheumatological condition, which is called vasculitis, and that is where we will take it together. When I talk of large vessel vasculitis, I have 2 predominant things in my mind. One is a TAC. What is a TAC? TAC is a Takayasu arthritis. Takayasu arthritis. And we have something called a GCA, which is a giant cell arthritis. Okay? So Takayasu's arthritis, for someone who is not aware of the full forms, you can write this down: Takayasu arthritis and giant cell arthritis. So GCA is giant cell arthritis. That is what we come across when we talk of a large vessel vasculitis. Now, there are certain features which are very common in large vessel vasculitis in these 2. There are some things which are new, which we'll be studying accordingly. Let's first focus on Takayasu. So in Takayasu, you can hear the name Takayasu and say this has got to be a Japanese name, correct? I mean, Takayasu, anyone who's hearing the name will know that this is a Japanese name. So it's something which was discovered by Dr. Takayasu himself. And I do not know if you know this. He lived till 101 years. He survived till COVID. I mean, he succumbed to COVID in the year 2021, but he survived till 101 years, and he made immense research and contributions in the field of rheumatology, and especially vasculitis. So this vasculitis is named after him. Takayasu's arthritis, and mainly it is going to involve young males and young females, predominantly young females, I'll say. So most rheumatological disorders in this world are female predominant. A lot of genetics, a lot of other epidemiologies come into factor, but Takayasu mainly comes with young males and females. I'll still say a bit of more females. And when I say young, what do I mean young? Young is in the context of less than 40 years. So the parts which are not filled are for you to fill. So Takayasu arthritis is for young males and females, mainly females, less than 40 years. Now, whereas giant cell arthritis is something that is occurring in the older age groups, that's more than 50 years. So that's one predominant difference, that one is involving the younger, one is involving the older. You can even remember it as giant cell arthritis. Giant matlab somebody who's old, big. So giant cell arthritis is somebody where the older females are being involved more than 50 years. Okay, now let's come to renal involvement. When I talk of renal involvement, one thing that we need to know is Takayasu's arthritis has something which is called renovascular hypertension. So you can keep on filling this box beside renal. Renal is renovascular hypertension that is found in Takayasu's arthritis. I already told you Takayasu is a large vessel arthritis. When I talk of a large vessel, I'm predominantly meaning arteries like renal arteries. Renal arteries coming directly from the descending abdominal aorta, right? Everyone in sync with me? So descending abdominal aorta giving rise to the renal artery, which is a large vessel, and involvement of this can occur in Takayasu arthritis, leading to something called renovascular hypertension. But in case of GCA, giant cell arthritis, very rare renal involvement is there. Very rare renal involvement is there. So till now we know 2 things. Older patient, female, more than 50, goes in favor of GCA. Younger female, younger male, less than 40, goes in favor of Takayasu. Renovascular hypertension, more in Takayasu, rarely seen in GCA. Now, when I talk of large vessel, I'm predominantly meaning one is a renal blood vessel, one is a pulmonary blood vessel, right? In the pulmonary blood vessel, again, rare involvement in both Takayasu and giant cell arthritis. Next, we are coming to PN. What is PN? It is peripheral neuropathy. Is peripheral neuropathy found? No. Peripheral neuropathy, we'll remember this. Peripheral neuropathy, when you talk of peripheral neuropathy, I'm predominantly meaning the nerves which are supplying the digits or the digital extremities. So they are already going to be supplied by small vessels. So very rarely will you find that a large vessel vasculitis is going to produce a peripheral neuropathy. I repeat, peripheral neuropathy is a disease wherein you find numbness of the digits, you find tingling sensation of the digits, mainly something that you encounter in a disease called diabetes. These people on a chronic long-standing diabetes will come to you and say, I'm having tingling of my digits, numbness, tingling sensation in my digits, pain in my digits. So all these extremities of the digits are something which is supplied by the small vessels, not the large vessels. So peripheral neuropathy is relatively very, very rare in a large vessel vasculitis. GI involvement, again, is rare in cases of both Takayasu and GCA. The skin involvement, again, is rare, which makes us think that, okay, two things is for sure. Takayasu and giant cell, both are large vessel vasculitis. Takayasu involving the renal, giant cell does not involve renal or any other system like the lung, does not involve the GI, does not involve the skin. What exactly then it is? What is giant cell? What is Takayasu? Giant cell arteritis typically is a patient who will be, above 50 years, female, who will be coming to you one fine day and saying, doctor, for the last 3-4 years, I have been having this throbbing kind of headache along this region of my face. If you can see, if I remove my specs, along this region, there's a throbbing kind of a headache. And it's so painful at times. The pain increases in frequency and duration. At times it decreases on its own. But when it is there, it is so much pain that I can barely chew my food. I'm repeating my words. I can barely chew my food. So this patient, an older female, more than 50, coming and telling you that she's having a pulsatile throbbing headache. You might think of migraine, you might think of the other things related to headaches, but the moment she tells you that the pain increases on chewing food. So when we chew food, you can see I'm contracting my masseter and the buccinator muscles. If you can feel your own buccinators and the masseters, when you chew something, this is the one area which is becoming very tense. And these patients will continuously complain of something which is called a jaw claudication. Jaw claudication. What is jaw claudication? That is in fact the most common symptom. Here, by mistake, most common symptom under GC has been written as STA. Please correct that. It is jaw claudication. So this patient will tell you that whenever I am having food, I am having a typical amount of pain and I'm not able to chew food. There's somebody who's written, Dr. Twinkle has written, it may mimic trigeminal neuralgia. Absolutely, that kind of headache may mimic trigeminal neuralgia indeed. So what happens actually in trigeminal neuralgia, you don't just have pain along this area, you also have pain when you're striking these areas. If you remember this famous, we have a famous celebrity called Salman Khan. He's been having trigeminal neuralgia all these years. If you tap in these areas of the trigeminal nerve, there's a burning, pricking pain like sensation which you have, but that is an intermittent pain. Again, I'm repeating, in trigeminal neuralgia you don't have pain all the time. When somebody is stimulating in these areas, then you have that pin pricking sensation. But this patient is going to complain of a continuous pain. She'll say that the pain is out of proportion, that whenever I'm chewing my food, there is so much of pain that I'm not able to chew my food. So this most common symptom is jaw claudication in GCA. What is the most common vessel? In these patients, you'll be finding that this vessel is often going to be enlarged. I'll be showing you to you in a few minutes. This vessel is the superficial temporal artery. So we know we have our heart, our coronary artery, we know the circulations. So one thing that we surely know is from the ascending aorta, we are having the internal carotid artery and the external carotid artery. One branch of the external carotid artery is the superficial temporal artery. In these patients, the vessel that is involved is the superficial temporal artery. So STA is superficial temporal artery, which is a branch of ECA, external carotid. That's the most common vessel involved. Most common symptom, as I already told you, is jaw claudication. And another symptom that we typically come across is headache. So headache is what they most commonly come to us, but very, very specific is jaw claudication, because in migraine, in trigeminal neuralgia, none of the other causes of headache that you think of will you ever have jaw claudication. So jaw claudication makes it very specific. Most common symptom is headache. Now, these patients, when they come, so I'll tell you something. GCA is very, very, very rare in India. It's not very common in India. It's something which is very predominant in the Western world. Before I take this, I'll tell someone to please take me the slide forward, 2 slides forward to the images, 2 slides forward to the images, please. The next slide. Yes. Can you see this first image? No. Just the previous slide. Just the previous slide. Yes. Can you please see the first image? Can you please see the first image? Can someone move the cursor on the first image that is being shown? Yes. Fantastic. Can you zoom this image for me? Can you zoom this image for me? Can you zoom that image for me? Can we have a zooming in?
Doctor, I'm trying. I'm not able to do. Sorry.
Yeah, okay. Even if we can't zoom in, it's still very visible. Please take me back to that page. Take me back to that image page. Yes, and when we see this page, image page, can you see this thickened cord-like vessel? Can you see a thickened cord-like vessel? So you can see this very clearly. There's a thickened cord-like, yes, exactly. That's the thickened cord-like vessel. And I'll tell you 4 words that I want you to write down. This is why I've kept this blank. So it's a painful, it's a cord-like, and it's a pulsatile. I mean, it's a pulseless temporal artery. I repeat, it's a painful, it's a cord-like, it's a pulseless temporal artery. What do I mean by pulseless? I want you all to clench your teeth and put your fingers here. The moment you clench your teeth like this and put your fingers here, you can feel the pulse of the temporal artery. But in these patients, when you tell them to clench their jaw or teeth and feel the pulse, there'll be an absent pulse. So a pulseless temporal artery with a cord-like thickening, a painful cord-like thickening in a older female, more than 50 years, who's coming to me with headache and also complaining specifically of jaw claudication, should make me think about giant cell arteritis. What is there in the image that is just below that? Somebody points the cursor down there. Yes, is this image just below that? Yes, exactly. Can you see something? So this exactly is the histopathological section of the superficial temporal artery that has been taken. Any artery we know has got 3 layers: tunica externa, tunica media, and tunica interna, right? So there are 3 layers: intima, media, and externa are the 3 layers of a vessel wall. Can you see something? Suddenly there's a white thing there inside. Yes, so that white thing that you see is a total disruption of the internal elastic lamina. It's a disruption of the internal elastic lamina. So 4 buzzwords when I talk of GCA: older female, more than 50, most common symptom, headache, specific symptom, jaw claudication. On examination, I find a pulseless, cord-like thickening, painful thickening of the superficial temporal artery, which is the most common vessel involved. On the histopathological examination, I am finding a disruption of the internal elastic lamina, makes me points towards a diagnosis of giant cell arteritis. Am I clear? Can I have a thumbs up from everyone in the chat box? Any doubts? Any doubts? So you can take me back to the older slide, previous slides, please. The previous slide. Yes, no, yes, that's perfect. This is the slide. No, just the one that we were talking of. Yes, perfect. So that's about giant cell arteritis. Now let's come and focus about Takayasu's arteritis. What is Takayasu? We already talked. It is going to be a young male predominant disease or a young female predominant, less than 40 years. The most common vessel that will be involved is now the subclavian vessel. Most common vessel is the subclavian vessel. What is subclavian vessel? I'm mainly talking of the subclavian artery. Again, it is a branch of the carotids. Again, it's a branch of the external carotid artery. What happens in these patients? They'll come to you. So a young female coming to me and saying that I'm usually having a pain along my arms. Usually I have a pain along my arms, but the pain increases when I'm raising my arm over the head. The pain increases when I'm raising my arm over the head. Otherwise, the pain is not there. Usually it's without pain. But the moment I raise my arms over the head, I find 2 things. Number 1, that the pain increases. Number 2, I often feel dizzy. And when someone checks my pulse there's an absent radial pulse. So 3 things. A young female coming to me, less than 40 years, saying arm pain is there, and it's a cramping kind of arm pain. When I lift my hands, it seems the pain is increasing, and along with it, the pulse is absent when I raise my hands. So often these patients will have an absent radial pulse. So most common vessel involved is the subclavian artery. The symptoms that you see are arm pain, claudication, and no radial pulse during that phase of putting the arm above. The investigation of choice, because it's a vessel problem, we will always go with CT angio. CT angio, because we have to look at the site of the block. How will we see the block? Please take me back to the images slide, sir. Take me back to the images slide. Yes. Now, please focus on the second image. Please focus on the second image, sir. Yes, that's it. Since we can't zoom in, even if you can't zoom in, can you clearly notice that this black thing is something which yes, so that is entirely what I'm talking of, is the aorta. That's basically the aorta, the ascending aorta, and then it's becoming gradually going to be the descending aorta. Can you see that it has taken out 2 branches above it? 2 branches taken up above it, yes. And one of these branches, the second branch rather, has got a total block. There's an occlusion. Exactly where sir was pointing a little bit while, a little 2-3 seconds back. Yes, whenever you can, yes, that is exactly the site of the block. So the subclavian vessels are what is supplying the blood to the head, it is supplying the vessels, the blood to the arm, especially the upper limbs. So the moment there's an occlusion there and you're lifting your arms, there is going to be pain. And because of this, there's an absent radial pulse as well. So the second image is what I have of Takayasu's arthritis. Can we get back to the table that we were talking of? Great. So right now, two diseases are sorted. Takayasu is an occlusive disease. Because there is occlusion, I need to see where the occlusion is, and the best way of seeing an occlusion or a block in the vessel is a CT angiogram. So that is why it is the investigation of choice. The investigation of choice is always going to be a CT angiogram. And the treatment of choice of any vasculitis or any rheumatological condition is going to be corticosteroids and immunosuppression. In Takayasu, we can give methotrexate. But right now, I'm not going to focus on the treatment part because immunosuppression is something that left and right any person on this earth knows. Rheumatology means immunosuppression, steroids. That's not the main thing that I want to say. The main thing I want you to know about the disease itself. So I have sorted two diseases in my mind right now, both being large vessel vasculitis. One is a young female coming to me, and why am I repeating this? So that this stays in your head. A young female coming to me telling me that whenever I lift my arms, there's pain, there's arm claudication, absent radial pulse, and I check a CT angio, I find there's an occlusion in the subclavian vessel, which is the most common vessel involved. This is Takayasu's arthritis. The second case that I talked of is an older female coming to me, more than 50 years female, coming to me and saying that I have a headache for a very long time, and especially when I'm chewing food, the headache seems to increase out of proportion. So on examination, I find a painful, there's a cord-like thickening, pulseless temporal artery which is there, and that is an example of giant cell arteritis. Because the second one, that is giant cell arteritis, is not an occlusive disease. There is no obstruction. I need to take a biopsy from the superficial temporal artery, which is the most common vessel involved. And on biopsy, I find that there's a clear disruption in the internal elastic lamina. So that completes two diseases for me. What is the treatment of choice for giant cell? Along with corticosteroids, you have something which is tocilizumab. Tocilizumab is something which is an IL-6 inhibitor. And this was, very much in rise during, we have heard the name of this drug so much during the COVID pandemic. And tocilizumab is something that has been shown to give a good response in patients with giant cell arteritis. Now, the moment that I cover up my large vessel vasculitis is completely done. I have sorted out giant cell. I have sorted out Takayasu. There's one disease which is out of the box, but looks very much under the classification of giant cell. That is PMR. What is PMR? It is polymyalgia rheumatica. That's something that I want you to write. So polymyalgia rheumatica, that's PMR. And the PMR is something that mimics giant cell arteritis and Takayasu in so many ways, but there are certain specific things to PMR. In India, rather, I'll tell you, PMR is very common. In India, PMR is very common. Giant cell arteritis is very uncommon in India. It's more in the Western world that we find giant cell. In India, PMR is extremely common. And I'll tell you why it is common. Most doctors who have been practicing, or even the ones who are doing your internship, you'll find this patient so many times in your OPD. So there'll be an elderly female who will be coming to you around 60, 65 years old. And she'll be coming to you and complaining of non-specific sites of pain. Like she'll be saying, I have a pain in my shoulder girdle. I have a pain in my pelvic girdle. I have a pain in my elbows. So the girdles, mainly the girdle areas, are the areas that will be involved. So the pelvic girdle, the hip girdles, the knees, that will be involved. And it'll be an elderly female. Along with it, you'll ask her what else. She'll say, I usually have a very, very mild feverish kind of feeling throughout the day. The mild feverish feeling, as if I'm not willing to work. I feel that, I'd rather take some rest. And when you actually see the joints, you'll find that, okay, the joints look a little bit inflamed. They look a little inflamed. And, when you move the joints, she'll say, okay, I'm feeling pain. I cannot move these joints very much. Mainly when I move my shoulders, I feel that my shoulders are stiff. I cannot move my hips very well. It feels very stiff to me. And along with it, they might complain of headache. How many times have you found such a patient? Tell me, how commonly have you come across such a patient in the OPD where an old elderly female around 60, 65 is coming to you saying that mujhe bukhar jaisa lagta hai, I feel feverish throughout the day, on and off. I don't have fever. When I check my temperature with thermometer, it's usually okay, but I feel feverish. I have a mild headache. My shoulders feel stiff. My hips feel stiff. My joints feel a little stiff. And how many times we just say that, okay, it's osteoarthritis. Can anyone in the comment box please share this? Are you well aware of these patients? Because you'll have a lot of patients of PMR in India. Trust me. Even for a non-rheumatological setup, you'll have a lot of patients of PMR. Anyone who's come across such patients, even maybe during an internship in your practice, have you come across such patients? Have you come across? Yes. So yes, there's someone, Dr. Twinkle, came with polyarthralgia with swelling. Investigation showed elevated ESR, elevated CRP. Exactly. So this is such a common variety, such a common entity that we find in India. So this PMR is something which mimics a large vessel vasculitis, which is why I've kept it out of the table. It is something which mimics a large vessel vasculitis and is a very common presentation in India. However, it is not a vasculitis. So when I talk of PMR, I talk of four things. One is S for stiffness of the girdles, E for elderly patient, C for constitutional symptoms like fever and myalgia, R for rheumatica, yani ki, pain in the joints, rheumatic features are there. And yes, very often in the orthopedic OPD. Exactly. So Dr. Trivendras is very common in the orthopedic OPD. Fantastic. Yes, there's elevation of ESR and CRP, as Dr. Twinkle said just a while ago. And we may find some temporal arteritis features, like some GCA features may be there. She might say have a bit of headache, but no jaw claudication. I repeat, there'll not be any jaw claudication. So these 4-5 features are something which we see very commonly in India, very commonly encountered. And this is something which is polymyalgia rheumatica, should not be confused with a large vessel vasculitis. That completes the entire section of a large vessel vasculitis. Let's now come to a medium vessel vasculitis. Is everyone good with large vessel? Everyone good with large vessel? Give me a thumbs up. Everyone? Any doubts from large vessel vasculitis? Similar case in posting. Yes, exactly. Fantastic. I'm so thrilled with the response that I'm getting. How to differentiate between osteoarthritis and PMR? Okay, fantastic. Good question. Very good question. Who's this person? Dr. Swishti. Very good. Good question. How to differentiate between osteoarthritis and PMR? Okay, so I'll tell you something. I'm giving you a basic rule, my friends. I'm giving you a very basic rule. And the rule says, how do you differentiate whether a pain in the joint has to be seen by an orthopedician or has to be seen by a rheumatologist? Is that also your question, Srishti? Srishti, can you confirm me? Is that also your question? That, doc, how do I differentiate between a pain which is to be seen by a rheumatologist versus a pain that is to be seen by an orthopedician? Yes, exactly. Fantastic. I love this question because, in fact, I've seen so many people, get this wrong. So let me give you a basic dictum. If you wake up in the morning, see, if I'm the patient, if I wake up in the morning and on waking up in the morning, I feel so much of pain that I can barely move, but I still push myself off bed and start working, within 30 to 45 minutes of initiating work, my pain reduces in intensity. Again, I'm repeating. I wake up in the morning after a good night's sleep with immense pain in my joints. And on moving around for 30 to 45 minutes, doing basic household stuff, brushing, freshening up, if my pain reduces, it is a rheumatological pain unless proved otherwise. Because any inflammatory pain that occurs in rheumatology will always improve with exercise. Why? Inflammation means more blood flow to that area. So if it's an inflammatory pain, it will improve with exercise and deteriorate with rest. So a pain that is good in the morning with exercise, but it's bad when you are resting for a long while, is a rheumatological pain. You need to go to the rheumatologist. A pain, on the other hand, which worsens with exercise, but is good when you rest, is an orthopedic pain, should be seen by an orthopedician. Usually, I'm not saying always, but a general rule is this, number one. Number two, if you are having any joint which is red and swollen, and your ESR and CRP values are elevated. I repeat, a joint, any joint, it can be a finger joint, it can be a shoulder joint, a knee joint, doesn't matter. Any small or large joint, when the problem is that they are swollen, they are tender, ESR, CRP are raised, and somebody wrote here, Dr. Twinkle, that yes, the movement in the first step causes pain. That is exactly an osteoarthritis pain. So again, I repeat, pain on the first step of movement, deteriorating with more walking and more pain. So exercise is not improving that pain, and ESR, CRP are usually normal. No swelling and tenderness or inflammatory signs like redness in the joint, no fever. Most likely it is orthopedic pain that is due to osteoarthritis. Any pain, you wake up in the morning, seems very bad, but gradually improves in the day within 30 to 45 minutes of activity, high ESR, high CRP, signs of inflammation is there, like swelling, like tenderness, like redness of the joint, should majorly be seen by a rheumatologist. Is that clear? Is that clear? Okay. Thank you, Srishti. If female walks about 1 kilometer after her foot is having so much pain, what is diagnosis? Okay. So I'll, okay. Sorry. It seems at times I'm having to tell you things outside vasculitis as well, but I'll take this question because it's a good question. Okay. So pain on walking in the first step, pain on walking in the first step can be an osteoarthritis pain as well. Pain on walking in the first step can be an osteoarthritis pain. Pain on walking in the first step can also be due to a nerve involvement. So that also needs to be seen. So whether it's a nerve involvement which is causing the pain. Pain on walking in the first step can also be seen if there's a slipped disc. That also needs to be seen. So whenever we evaluate a pain for anyone, male, female, whoever it is, on who is having pain during walking, if the other signs are normal, we first rule out occlusion via doing a USG and a color Doppler. We see whether the blood flow in the limbs is proper or not. If the blood flow in the limbs is proper, we then rule out whether it is an osteoarthritis induced pain or a slipped disc induced pain using a spine MRI. A spine MRI will clearly tell me whether there's a slipped disc or not, right? If there's slipped disc, you manage it accordingly. If there's no slipped disc, you now think in terms of osteoarthritis. You check whether there's any osteophytes which have developed in the in the ankle, in the calcaneal bone, and that is how you evaluate the different things of pain. So a pain in the first step can be a neuropathic pain. A pain in the first step can be an osteoarthritis pain, and a pain in the first step can also be after a point of a severe occlusive disease that is occurring in the legs. So these are the three differentials of pain on walking. Is that clear? And slip disc also is one of them. Is that clear? Dr. Ajay, is that clear? Fantastic. Treatment, again, if it's a slip disc, you need to assess rehabilitation. If it's severe, surgery, medical treatment, at times steroids to reduce the compression of the disc on the surrounding areas. If it's a neuropathic pain, you will give pregabalin, gabapentin, which is like things to reduce that pain. So pregabalin works very well. Neuropathic pain, pregabalin and gabapentin are excellent. If it's due to diabetes, you will also control the diabetes because many patients of diabetes do have a neuropathic pain as well associated with it. If it is a vasculitic problem, foot pain is not a cause of vasculitic problem in any way. So rules that out. If it's an orthopedic issue, if you feel that the woman needs to wear soft sole shoes, you'll give her soft sole shoes, you'll give her a bit of painkillers, and you'll show her some exercises, makes it good enough for her. Calcaneal spur, that's why I told you that you need to check whether there are osteophytes, you need to check whether there's a calcaneal spur. Most of these patients who are having calcaneal spur will require a soft sole shoes as well. Is this clear? Is this clear, Dr. Ajay? Fantastic. Okay. Let's move forward now. Let's move forward to our next vasculitis, which is medium vessel vasculitis. No, I'll still stick to that same slide, sir. I'll still stick to the same slide. I'll tell you when to go to the next one. So when I talk of medium vessel vasculitis, mainly I'll talk of two. One which we find in the elderly age group, that is PAN, polyarthritis nodosa. The other that we find in the younger age group, that is Kawasaki, which I'll talk in the very end. Kawasaki is what I'll talk at the very end, but PAN is what I'll really talk about now. PAN is polyarthritis nodosa. Polyarthritis nodosa, whenever I'm talking of polyarthritis nodosa, I am meaning it's a medium vessel vasculitis, and it is going to usually involve middle-aged people, middle-aged male, middle-aged female. But one specific association has been found that 30 to 40% cases of PAN have also an associated HBV positivity, hepatitis B positivity. So there are two vasculitis we'll study today with respect to hepatitis virus, hepatitis B and PAN, and hepatitis C and cryo. So how I remember is pan is something that we have in India in different states. I think everyone is aware of pan, a food that we have. I mean, it's a betel leaf. Everyone is aware. Can you give me a thumbs up? Please, someone who doesn't know pan, you know what pan is? There's a betel leaf and you put on those, different sweet fillings inside. You have those fire pan, you have Coca-Cola pan, now you have chocolate pan. Aware? Fantastic. So how I remember it is pan khata bacha, right? So a bacha is B for bacha and it's hepatitis B with pan. and PAN rather, and Hep C goes with cryo. So cryo starts with C. C for cryoglobulinemia. Cryoglobulinemia is starting with C for cryo, and hepatitis C is associated with cryo. Is that good to remember now? Can you remember this now? Hepatitis B is with pan khata bacha, and Hep C is with cryo. Is that good? So two viruses associated with vasculitis. One is Hep B associated with pan, Hep C associated with cryo. Is that good? Fantastic. Now, when I'm talking of medium vessel vasculitis, pan, that is polyarthritis nodosa, 30 to 40% cases of pan have been associated with hepatitis B patients. Now, how is the involvement? Mainly it is involving middle-aged people, as I told you, 30 to 40% associated with hepatitis B. When I talk of renal involvement, you typically find microaneurysms in the renal vessel. Now, please listen to me very carefully as I say it. This is not a renal artery involvement that we found in Takayasu. In Takayasu, we were talking of renal artery involvement, which is a large vessel. Here, I am saying the other renal vessels. When I talk of kidney, it is not just the renal artery, right? There's also the glomerular capillaries. There's also the Bowman's capsule. So there are many other vessels which are involved. It is not the renovascular hypertension, which is why renovascular hypertension can never be found in PAN. Renovascular hypertension was found in Takayasu. It was involving the renal artery. When I talk of PAN, it is going to involve other renal vessels, but will never involve the glomerulus. Because the glomerulus is small vessel. A glomerulus is supplied by a tuft of capillaries, which are a small vessel. Because glomerular involvement is not there in PAN, we do not find glomerulonephritis. We do not find an RBC cast. Is this clear with everyone? Because glomerulus is a small vessel and PAN is a medium vessel vasculitis. Because glomerular involvement is not there, we do not find glomerulonephritis, and because there is no glomerulonephritis, there is no RBC cast. Is that clear? I repeat again. Yes, I'll repeat this again, Dr. Twinkle. So I said that in Takayasu, we have renal involvement as renovascular hypertension due to renal artery involvement. In GCA, we do not have renal involvement. Finished. In PAN, we have renal involvement, but it will not involve the renal artery. It will not also involve the glomerulus because the glomerulus is a small vessel. And because there is no glomerular involvement, it will not lead to glomerulonephritis. It will also not lead to an RBC cast because we know glomerulus being involved causes glomerulonephritis and causes an RBC cast to come in the urine. Because glomerulus is never involved in PAN because it's a medium vessel vasculitis and glomerulus is a small vessel. PAN is a medium vessel vasculitis. Because it's a medium vessel vasculitis, glomerulus is never involved. Because no involvement of glomerulus is there, it will never lead to glomerulonephritis. It will never lead to an RBC cast. Is that clear? Dr. Twinkle, is that clear? Fantastic. Very good. Very good. Now, so what do we find? We may find hypertension, we may find hematuria, but we will never find a glomerulonephritis. We will never find an RBC cast. Is that clear? Please, sir, take me to the image section. I'll show you how the microaneurysms look in renal blood vessels. Please take me to the image section. Please take me to the image section. Yes. Can you see the third image, sir? You can point it out. Yes. Can you, since we can't zoom in, I don't know, I'll try to make sure that the images are zoomed from the next time. Now you can clearly see I've marked it with the black arrows. The black arrows are visible. If the black arrows are visible, I'm not able to see the slide.
1 second, I'll try to zoom it.
Yeah, absolutely. I think that would be better for the students. Yes, fantastic. Yes, that's perfect. So yes, can you now see everyone? Is this clear for everyone? Can you please give me a thumbs up if the slide is seen better now with the zooming in? Everyone, can I have some messages? Yes, fantastic. Okay, so you can see this. So if you can see this, there are microaneurysms being formed in the renal blood vessels, which are marked with the black arrows. Exactly. So these are the microaneurysms which are found in the renal blood vessels. But repeating again and again, glomerulus is never involved because glomerulus is a small vessel. Because of no involvement of glomerulus, there is no glomerulonephritis, no RBC cast. Okay, let's come back to the table again. Let's come back to the table. So you can just click on slide share. Yeah, and we can come back to the table. Yes, yes. Absolutely. Yes. We can just zoom out a bit. Yeah, perfect. Perfect. That's perfect. Yeah. So whenever I'm talking of renal system, so microaneurysms are very common. Pulmonary system is not involved in PAN at all. Again, see, just look at the name of the. I mean, see, things are very simple. Once you study it, PAN khata bacha makes it Hep B positive and PAN. PAN is itself telling you that pulmonary artery is never involved. Pulmonary artery, N for no pulmonary artery involvement. Can you see this? Can you see this, everyone? Is it visible? PAN, pulmonary artery not involved. PA, pulmonary artery, N for not involved. Okay. Now, is there polyneuropathy that can develop? Yes. It can develop as distal symmetric polyneuropathy, or it can develop as mononeuritis multiplex. Distal symmetric polyneuropathy or mononeuritis multiplex. Yani ki, what is mononeuritis multiplex? Different parts of the neurons which are supplying the endings, the nerve endings in the digits, they will start being inflamed, and that can lead to pain, tingling, and numbness. Okay. GI system again will have microaneurysms. We'll see the picture in a while. GI system again will have microaneurysms. You will find the mesenteric blood vessels showing microaneurysms, and there will not be any granuloma. In the skin, you'll find something typical, which is also very commonly found in a small vessel vasculitis, that is palpable purpura. What is purpura? Purpura actually means that there are lesions which are found on the skin, which are reddish raised lesions. I'll show the purpura in a while to you, and they are palpable, means you can feel them. But please mind it, none of these purpuras are associated with low platelet count. So two things that I'm telling you. When I talk of palpable purpura, the first thing that you should think is it is a vasculitis. The second thing that you should think is most commonly it is small vessel vasculitis. But the only medium vessel vasculitis where you may find purpura is a PAN. Am I clear? Three things. When I talk of purpura, it's a vasculitis. Palpable purpura, that is, it's a vasculitis. When I talk of palpable purpura, it is a vasculitis and mainly a small vessel vasculitis. When I talk of the only medium vessel vasculitis which can show palpable purpura, it is PAN. What else about PAN do we know? PAN is PAN, PA, no involvement of the pulmonary artery. What else do we know? PAN khata bacha, that is B for hepatitis B, is involving 30 to 40% cases of Hep B have PAN associated with them. Clear? Am I clear? In renal system, in GI, you have microaneurysms. Again, I want sir to take us to the image section. Can we have the image section again? I would not need you to zoom anymore because the image that I'm talking of is very, very visible. Can we have the image section again? Yes. So just next to the third image, so I'm talking of the fourth image in the series. Yes. So this is the mesenteric microaneurysms that you see. The third image was the renal microaneurysms. The fourth image that sir is pointing right now is the mesenteric microaneurysms that you would see. Okay. When I talk of purpura, can you see the exactly image that is below the microaneurysms? Can sir point the image which is red in color, a red like skin lesion over the legs? Yes, exactly. So can you see reddish raised lesions? This is typical of a palpable purpura. Again, when I say palpable purpura, most common small vessel vasculitis, but only medium vessel vasculitis which shows palpable purpura is PAN. Is purpura associated with thrombocytopenia? No, it is not associated with thrombocytopenia. Purpuras are usually not associated with a low platelet count. These are the only things that I want you to keep in mind whenever you're seeing this. Okay, let's go back to the slide again. Yes. So PAN is usually done. There are two things that I want to tell you. Number one is what is a unique feature of PAN? So one unique feature of PAN is it can lead to testicular involvement. One unique feature of PAN, just give me a moment. Yeah, one unique feature of PAN is it can lead to testicular involvement in males. That is one thing which you should keep in mind. And as I said, association, 30 to 40% cases of PAN have association with hepatitis B virus. That's PAN khata bacha for us. When I talk of PAN, if you want to revise this disease in 4 words, because we have been talking about the diseases, we have been also making a short revision of the diseases. If I have to revise PAN with you, I'll mainly tell you to revise the 4 no's in PAN. Yani ki what are the things that are not there in PAN? Number 1, it is not associated with ANCA. What is ANCA? Will come in small vessel vasculitis. ANCA is a test it's a test of anti-neutrophilic cytoplasmic antibodies that we test to see whether they are present. If they are present, we say it's a case of ANCA-associated small vessel vasculitis. But PAN is a medium vessel vasculitis, so it will not have ANCA. So no, 4 no's mean the first no is not associated with ANCA. The second no is no RBC cast. And what is the cause of no RBC cast? Because RBC cast, for RBC cast to be there, it has to be a glomerulonephritis. For that, glomerular blood vessels, that is small blood vessels, should be involved. But PAN is a medium vasculitis, medium vessel vasculitis. It will never involve the glomerulus, will never cause glomerulonephritis, never cause an RBC cast. So the one no is no ANCA association. Number second no is no RBC cast. Number 3 is no granulomas on biopsy. When I talk of granulomas, you will always remember this. Granulomas are never ever found in a medium vessel vasculitis. And number 4, pulmonary arterial involvement is not there. So no pulmonary artery involvement. Again, repeating the 4 no's all together. I want you all to repeat this in your own rooms or own space. Number 1, no ANCA association. Number 2, no RBC cast because there is no glomerulonephritis. Number 3 is no granuloma on biopsies because it's a medium vessel vasculitis. Number 4 is no pulmonary artery involvement. PAN, pulmonary artery not involved. Is PAN clear? Is PAN clear to all of you? Can I have a quick thumbs up? How to differentiate, investigate, sir, apart from CT angiogram? How to investigate this medium vessel vasculitis? How to investigate medium? Yeah, okay. So this patient, first thing is serology. If Hep B is positive and this patient is coming to you with mononeuritis multiplex, tingling sensation in the hands and feet, and you're finding it's a Hep B positive patient, and you're finding that this patient is usually having a palpable purpura on the skin, you should think of it. Palpable purpura will also take you towards small vessel vasculitis. You will be doing an ANCA. If ANCA is negative, you will be very sure it's not a small vessel vasculitis probably. And then you'll be thinking in terms of medium vessel vasculitis. You will be doing a CT angio and finding out mesenteric microaneurysms. If you find hematuria in this patient, if you find hypertension in this patient, should make you think about renal involvement. Hematuria is present, so again will make you think about renal involvement, and you will start thinking in lines of PAN. So that is exactly how it is. Is that clear, Dr. Twinkle? Any other doubts from medium vessel vasculitis or PAN? Medium vessel vasculitis, any other doubts? Clear, everyone? Shall we move on to the small vessel vasculitis? Shall we move on to the small vessel vasculitis? Shall we move on to the small vessel? Thank you. Very good. Thank you so much. Thank you, Dr. Jitin. Thank you, Dr. Twinkle. Okay, let's come back to the table, sir. Let's come back to the table. First of all, a big thank you to the tech team of Mediversal, because I am not able to share this from my end today. As I told you, I've been really stuck with a lot of things. And it's been really a very difficult week. The way sir is, managing the slide sections, I'm really glad and grateful to all of you, and for all the participants as well. I'm finding this webinar to be really interactive. So thank you so much. The last one on our list today is a small vessel vasculitis. This is extremely important. No. So we are going to stay on the same slide. The one thing that, all the participants, the one thing, if you can see very clearly, the one thing that I've ensured is, if you need to revise vasculitis, if you just revise this one page, it makes it enough. Everything is put in here. Also, what it does, it compares the 3 different vasculitis in one place. That makes you easier to understand what is what and what not. So that is something which I've always wanted. Bring things together in a place and make it comparative so that you can compare one thing with the another. Let's come to small vessel vasculitis. Whenever I'm talking of small vessel vasculitis, there's something which I want you to write very clearly and in bold. Can you see something? When we were talking of large vessel vasculitis, you found out the role of CT angio, right? CT angio was being done for Takayasu because there was, you had to see whether there's a occlusion in the subclavian artery. For giant cell, you did not need it because it was diagnosed on biopsy. Okay, for PAN, you needed CT angio again because you had to check the renal blood vessels for microaneurysms. You had to check the mesenteric blood vessels for microaneurysms. But whenever I talk of small vessel vasculitis, the one thing that is clear is angio is always going to be normal. So angio will be normal. Because angio is normal, the gold standard for the diagnosis of any small vessel vasculitis becomes a biopsy. I repeat, small vessels are not usually seen on angio. Hence, angio report will be normal. Because angio report is normal, if you want to diagnose a small vessel vasculitis, your gold standard examination is always going to be a biopsy. And not just biopsy, it will be a biopsy with immunofluorescence staining. Biopsy with immunofluorescence staining. Yes, exactly. Biopsy and immunopanel. Thank you. Thank you, Dr. Twinkle. Fantastic. Yes. It is going to be a biopsy with immunofluorescence panel staining. Okay. Now, whenever I am going for a small vessel vasculitis, a diagnosis will be depending on two things. Whether it is an ANCA-associated vasculitis, AAV is ANCA-associated vasculitis, or whether it is an immune complex mediated vasculitis. So, is it an ANCA-associated vasculitis or is it an immune complex vasculitis? Again, I'm repeating the entire thing. I have a case of vasculitis. CT angio looks problematic. I will think in terms of large vessel or medium vessel. I've already told you what to see for. Whether there is arm claudication, TAK. If there is a cord-like thickening, it is GCA. If I have hepatitis B association, mononeuritis multiplex, hematuria, hypertension, I'll think in terms of PAN. But what if the angio looks normal? I have to think of small vessel vasculitis. In a case of vasculitis with the angio normal, it is predominantly going to be small vessel. The moment I do immunofluorescence and biopsy, I may have two categories of small vessel. One is ANCA-associated vasculitis. The other is immune complex associated vasculitis. Okay. Under ANCA-associated vasculitis, we have a group of 3 disorders which we'll be talking of. In immune complex vasculitis, we have 2 disorders. One is cryoglobulinemia and HSP. HSP is Henoch-Schönlein purpura. Cryoglobulinemia and Henoch-Schönlein purpura. Yes, doctor. Yes, Dr. Supriya, Dr. Twinkle. Yes, it is ANCA-C and ANCA-P, which I'll be coming and talking of right now. So again, CT angio is going to be normal in small vessel, and hence biopsy is going to be the gold standard along with immunofluorescence. Based on biopsy and immunofluorescence, I'll have 2 categories. One is an ANCA-associated vasculitis. One is an immune complex associated vasculitis. Clear? Now, when I talk of ANCA-associated vasculitis, it means that immunofluorescence staining is negative. Immunofluorescence staining is negative in ANCA-associated vasculitis, and immune complex mediated vasculitis, the name itself says immunofluorescence is going to be positive. Because in ANCA-associated vasculitis, immunofluorescence is going to be negative, it is also called pauci-immune type of vasculitis. Pauci, P-A-U-C-I, pauci-immune type of vasculitis. Okay, so I repeat again, is PET scan better for vasculitis? I'll come about PET scan a little later. Let's just focus on the train right now. I'm very sorry. I'll take this question up. Please don't worry. If I don't take this question up, repeat the question again. I'll take this up surely. So again, under small vessel vasculitis, we will have this thing that is immunofluorescence positive, is immunofluorescence negative. If immunofluorescence is positive, it is immune complex. The name itself says immune complex mediated vasculitis. Immunofluorescence has to be positive. But if immunofluorescence is negative, then it will make me think it is a pauci-immune vasculitis. Pauci-immune goes with ANCA-associated vasculitis. So now let's talk of the epidemiologies. ANCA-associated vasculitis can come in any age. It's a variable presentation. I cannot really say, that it's a small vessel. I mean, it's that it'll occur in young, it'll occur in middle age. It cannot be said. It's a variable presentation. In the renal involvement for both. So again, can you clearly see this? I said this while discussing PAN, that PAN will never involve the glomerulus. Hence, because glomerulus is a small vessel, it will never be involved in PAN. No glomerulonephritis will happen in PAN. Only RBC casts will be there in will not be there in PAN. So whenever we come to a small vessel vasculitis, it will involve the glomerulus. It will cause glomerulonephritis, and hence both the small vessel vasculitis, be it ANCA-associated vasculitis or be it immune complex mediated vasculitis, both of them will come with RBC casts and glomerulonephritis. So that becomes a common feature. So again, when we look at the 3 types, any vasculitis coming to me with glomerulonephritis, hypertension, hematuria and RBC cast, I will straight away rule out medium vessel. It's gone. I will think a bit in terms of large vessel and small vessel. If my immunofluorescence is positive, if my ANCA is positive, large vessel goes out, and look how simple now this entire table, how simple it becomes to remember. So any glomerulonephritis concurrently, immediately rules out PAN, which is why I said PAN is something that is to be ruled out so fast. No pulm. That's why I said when you revise PAN, revise the 4 no's that I talked of. In one of those 4 no's was no RBC cast, because glomerulus is never involved in cases of PAN. When I talk of small vessel vasculitis, be it ANCA-associated, be it immune complex, both of these will have glomerular involvement, hence causing glomerulonephritis and an RBC cast. Okay. When I talk of pulmonary involvement, it is very common in ANCA-associated vasculitis. Hence, can you see the renal involvement is also there in ANCA-associated, the pulmonary involvement is also there, which is why the combination of the pulmonary involvement and the renal involvement in a small vessel vasculitis like ANCA-associated calls it the pulmonary renal syndrome. So the basic differentiating feature of a small vessel ANCA vasculitis with the other vasculitis is the presence of a pulmonary renal syndrome. Yani ki patient will have hemoptysis, coughing out blood along with hematuria. Whenever I have this presentation of a hemoptysis with hematuria, it will make me think of a pulmonary renal syndrome. If there's an RBC cast, I'm very sure it is a small vessel vasculitis. It cannot be medium vessel. It cannot be a large vessel, because if you see large vessel pulmonary involvement is very rare. Medium vessel pan pulmonary artery is not involved. So the only kind of vasculitis where you can have a pulmonary renal syndrome pushes your diagnosis towards thinking it's a small vessel vasculitis. Okay, now let's take this up. So this presence of a glomerulonephritis RBC cast with a pulmonary involvement in case of ANCA-associated vasculitis is what we call as the pulmonary renal syndrome. GI involvement again is very, very common in both the vasculitis, and even under immune complex vasculitis, these manifestations are more with cryoglobulinemia than with HSP. I'll talk of the diseases separately, but first let me put a comparative table in front of you. The skin involvement is again very common. I said the one word that should make you think that it's a small vessel vasculitis should be palpable purpura. I told you this clearly a few minutes back. Palpable purpura, most commonly small vessel vasculitis. Only medium vessel vasculitis with palpable purpura is going to be PAN. Clear? So small vessel vasculitis will come with palpable purpura. We have already seen the picture. And another question that I clearly told you is the platelet count in cases of palpable purpura is going to be normal. Palpable purpura is not associated with thrombocytopenia. It is not associated with thrombocytopenia. So the last thing about granulomas. Granulomas were a very common feature in large vessel vasculitis. Granulomas are also a very common feature with ANCA-associated vasculitis, except this entity called MPA, which is microscopic polyangiitis. Microscopic polyangiitis. Except MPA, granulomas are very common. So when I talk of granulomas, three things: very common in large vessel, never seen in medium vessel, very common in small vessel except MPA. That's how easy it is to revise. And you know, in the end, if I just take up anything, pulmonary artery involvement, never in large, never in PAN, only found in small vessel with renal syndrome, pulmonary renal syndrome makes it a case of small vessel vasculitis. That is exactly what I want you to remember. What kind of vasculitis we see in common practice? We see all of them. In India, if you ask me, predominantly we find PAN, predominantly we find small vessel, majorly small vessels and PAN. Takayasu is found very rarely. GCA, I have hardly seen GCAs in India till now. I have seen a few, but then very atypical presentations. PAN is found in India, yes, and small vessel vasculitis are very, very, very common in India. Very common in India. Okay, so till this much, is there any doubt? In small vessel vasculitis, one thing is palpable purpura, skin involvement you will have. Granulomas you will have, except in MPA. You will have pulmonary renal syndromes, predominantly in ANCA-associated vasculitis. ANCA-associated vasculitis is IF negative, that is post-immune. Immune complex vasculitis is IF positive, that is immune depositions are there. Is that clear? Is that clear? If this is clear, let us move to the two entities that I want to discuss in ANCA-associated vasculitis, that is GPA and eGPA. I could have told sir to shift to the next slide. I will not. So I'll first tell you the features, then we'll concurrently check the features that we find. What is GPA? GPA is granulomatosis with polyangiitis. And when I talk of granulomatosis with polyangiitis, the earlier name for this was Wegener's granulomatosis. Wegener's granulomatosis. And as I said, both GPA and eGPA are ANCA-associated vasculitis, which means ANCA is going to come out positive. There are two types of ANCA that we have. Okay, one is a C ANCA, that is a cytoplasmic ANCA. One is a P ANCA, that is a perinuclear ANCA. The name is very simple. Cytoplasmic ANCA means the green color of autofluorescence or the immunofluorescence that you will find will predominantly be staining the cytoplasm of the cells. whereas perinuclear means it will be staining the region just surrounding the nucleus. So perinuclear, P ANCA, and cytoplasmic ANCA, C ANCA, are the two types of ANCA that we find. When I talk of GPA, that is granulomatosis with polyangiitis, which is also earlier was called as the Wegener's granulomatosis, it's a triad of three things. Number one, ENT clinical features, ENT clinical manifestations, kidney manifestations, and lung manifestations. See, kidney and lung manifestations is a no-brainer. I just now talked of that ANCA-associated vasculitis have pulmonary renal syndrome. So, itna to is pakka that it will have lung involvement and kidney involvement. But the one thing that is very common in Wegener's is a ENT involvement. How I remember it, when you write W like this, doesn't it look like a reverse E? When you write a W like this, doesn't it look like a reverse E? So ENT manifestations with a pulmonary renal syndrome predominantly goes in the lines of GPA, that is Wegener's. And if I'm asked which ANCA is positive, which age group is commonly encountered with vasculitis, I think I've been saying this all over, right, Dr. Bilal? Takayasu is young females less than 40. Giant cell is older females more than 50. PAN, I've said it's middle-aged people. ANCA-associated vasculitis is more with, I mean, it's a variable disease. Even immune complex associated vasculitis is mainly with children more. I think I've been saying this. In case you've joined late, you can watch the recording. But yes, let's come back to this. Whenever I talk of Wegener's granulomatosis, that is granulomatosis with polyangiitis, I'm predominantly meaning there's a pulmonary renal syndrome, because pulmonary renal syndrome, as I said, is common in all ANCA-associated vasculitis. So kidney and lung are involved. W for Wegener's looks like a reverse E. ENT manifestations is also there in Wegener's. So ENT, lung, kidney, three involvement with a vasculitis makes me think about Wegener's. What are the involvements? I'll talk of later. If I'm asked which ANCA is positive in Wegener's, we know of this famous thing which comes every 4 years in India, in cricket, in World Cup, I mean in football, in hockey, other sports also. We have a World Cup happening every 4 years, right? FIFA World Cup, Cricket World Cup. Every 4 years we have a World Cup. So W for Wegener's granulomatosis, C ANCA is what it is associated with. So World Cup, WC, Wegener's granulomatosis is associated with C ANCA, whereas EGPA, or earlier it was also called as the Churg-Strauss syndrome, is associated with P ANCA. Is this clear? Is this clear? If a patient have infection in eardrum and small pore in eardrum, I'm so sorry, Dr. Ajay. I think this is more of an ENT based question, which I'll not take up now. In the end, when we have time, I can take this question up, but this is not at all a question pertinent to this topic. So I'll be not taking this question up. It's an earnest request. I'm really glad that you all are asking me questions, but please stick to the topic. Let's stick to the topic. Once we are done, after that, we can always talk on the other things, Dr. Ajay. Okay, I think you won't mind me saying this. Okay, thank you so much. So when I talk of this, I'm talking of two things. Wegener's granulomatosis, pulmonary renal syndrome is there, lung, kidney involved, along with ENT features. What is the ANCA associated? World Cup. W for Wegener's, C for C ANCA is associated. Clear? Now, what are the ENT features? These patients will predominantly see. Wegener's is a very difficult disease to diagnose. Why? Because by the time these patients are diagnosed, last 5-6 years already, they have been continuously just been seen by an ENT doctor. Because lung manifestations and kidney manifestations occur much later. What initially happens is the ENT manifestations. Like patients will come and complain of a recurrent runny nose. Recurrent runny nose, not even associated with seasonal variations. They'll say any time of the year, I have my nose blocked, my nose runs out. At times, they'll even have recurrent surgeries done for rhinosinusitis. Okay, they might have pharyngitis at times, sore throat, pharyngitis, recurrent attacks associated with otitis media, that is infection of the middle ear, and that usually is found due to the eustachian tube involvement. Whenever the eustachian tube, the tube which is connecting the nose to the pharynx, the nasopharyngeal tube, if there's an obstruction in the eustachian tube, it can lead to middle ear infection. So these patients may either come to you with recurrent rhinosinusitis like features, or these patients will be having a very long standing history of pharyngitis, of otitis media due to eustachian tube dysfunctions, or these patients may have presence of something called orbital granulomas, and because of the orbital granulomas, the eye may seem to be pushed forward. So, something behind the eye, there's a mass which is forming behind the eye, it will push the eyeball forward, which may look like a pseudoproptosis. I will request sir to take us to the image palette that we have, the image palette. Fantastic. So can you focus on the the one where there's a teeth where this patient is smiling? Yes, exactly. Can someone clearly see there's a strawberry gum that we find? This is called strawberry gingiva that is found in Wegener's granulomatosis. This is strawberry gingiva. The next image, which is just below the teeth, where this patient is having a typical nose pattern. Yes, the one just below below. Yes, exactly. So this is a patient who's been having recurrent rhinosinusitis like feature, recurrent sinusitis like features, and has undergone maybe surgeries in the past, recurrent surgeries, till a point that all his turbinates inside the nose have started to become deformed, giving me a typical saddle nose deformity. This is a very, very important question that is asked. One typical finding, ENT finding, is a strawberry gingiva. We have a saddle nose deformity. And the very next image that you have, the very next image, yes, is the case of a subglottic stenosis. You can see that the glottis is stenosed. This is a subglottis stenosis, subglottic stenosis. Along with it, can you see the very next image? Can you see the eye? Can you see the left eye of the patient? Yes, the left eye. Can you see the left eye? No, that's the right eye. Yes, that's the left eye that sir is pointing at. Can you see it seems to bulge out? Can you see it seems to bulge out? The other eye looks relatively so normal. This eye seems to bulge out because there's something behind the eye which is pushing it forward. So this is called an orbital granuloma, which can lead to a pseudoproptosis or a pseudotumor-like presentation. In the lung, can you predominantly see on this chest X-ray that there are white densities, white opacities rather, which are found in the predominantly lower lobes, and they look like cotton balls. So these are lower lobe predominantly cavitating nodules. They look like a cavity. If these similar nodules are found in the upper lobe, we'll be probably thinking of TB in a country like India. But these lower lobe opacities, which are cavitating nodules which are found, this is the pulmonary involvement that we get in these patients. And all these set of images here are all images of Wegener's granulomatosis. I'm repeating, Wegener's granulomatosis. W looks like E. So ENT clinical features. And the other two are very easy. Pulmonary renal syndrome is there. So kidney involvement, lung involvement. In the lung, what is the involvement? Diffuse cavitating nodules present in the lower lobe predominantly. In the ENT features, what is predominant? We have a strawberry gingivitis. We can have recurrent rhinosinusitis. We can have a saddle nose deformity. We can have a subglottic stenosis. We can have pharyngitis with otitis media and recurrent ear infections. And in the eyes, we can have a pseudotumor or a pseudoproptosis-like presentation, which will lead to the eye moving forward. So all of this are predominantly features of Wegener's granulomatosis. The World Cup, W for Wegener's, C ANCA is positive. When I talk of C ANCA, can anyone in the chat box write to me what is the antigen that we are testing in C ANCA? Anyone? It's a chocolate question. It's a chocolate question. Can somebody write to me what is the antigen that we are testing in C ANCA? It's a chocolate question. ANCA is the antibody that we are testing, right? Anti-neutrophilic cytoplasmic antibody. What is the antigen that we are targeting that antibody against? It's a chocolate question. Anyone? Yes, it is. The first prize goes to Dr. Nazia Qureshi, and it is anti-PR3. Fantastic. It is anti-PR3. Very good. Very good, Nazia. Nazia, as a leading question, what is the antigen that we are targeting in PANCA? What is the antigen that we are targeting in PANCA? To Dr. Nazia and everyone else. I'm really happy with the answers that you're giving. I'm really happy. I'm really happy. MPO, fantastic. A big hand to Dr. Nazia and to everyone else who are participating in this. So yes, when I talk of C ANCA, World Cup, W for Wegener's is targeting C ANCA, and the antigen that is targeted in C ANCA is anti-PR3. And when I talk of P ANCA, that is perinuclear, ANCA, the antigen that we are targeting is anti-MPO. Fantastic. Very good. Let's get back to the slide again. Let's get back to the first slide that we were talking of. Yes, that's the first slide that we were talking of. So we have completed Wegener's granulomatosis. Other name is GPA. Pulmonary renal syndrome is common because it is an ANCA-associated vasculitis. It will have pulmonary renal syndrome. Along with it, ENT features we have done. The second triangle is EGPA. Eosinophilic granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis. Kindly explain a rheumatoid vasculitis. What is rheumatoid vasculitis? Are you asking me the vasculitis that we find in RA, rheumatoid arthritis? Is that what you are asking me? Are you asking me that? Yes. Okay. So RA vasculitis, again, RA vasculitis is something that I will be talking in IC, immune complex mediated vasculitis. Just hold on for a while. We will be talking of the rheumatoid vasculitis that you talked of. Okay. Just hold on for a while, Dr. Bilal. Okay. So when I talk of EGPA, that is eosinophilic granulomatosis with polyangiitis, the other name is Churg-Strauss syndrome. Churg-Strauss syndrome. And what is something that we find in Churg-Strauss syndrome? There are again three things. Okay. First is, as I say, the name is eosinophilic. Can you tell me one respiratory disease that you think of which is allergy mediated, which is hyper eosinophilic? Anyone in the chat box? One respiratory disease which is associated with eosinophils and hyper eosinophilia. Yes, Dr. Twinkle, asthma. Fantastic, asthma. So these patients will have refractory bronchial asthma. Refractory bronchial asthma. What do you mean by refractory? That this bronchial asthma is not responsive to steroid therapy, not responsive to inhalers, not responsive to steroid therapy. So refractive bronchial asthma is the first part of the triangle of EGPA. The second thing is increased eosinophils. नाम में ही है eosinophilic granulomatosis with polyangiitis. So number one is refractory bronchial asthma. Number two is eosinophils increased. And number three is multisystemic involvement. When I say multisystemic involvement, it will involve the kidneys, it will involve the lungs, pulmonary renal syndrome will be there. Along with it, you can have a cardiac involvement, and indeed, cardiac involvement is the most common cause of death even in these patients of EGPA. Most common cause of death in EGPA is the cardiac involvement. You will also have mononeuritis multiplex like features. If you decide, we talked of mononeuritis multiplex just a while back in PAN. So one medium vessel coming with mononeuritis multiplex is PAN, but a small vessel coming with mononeuritis multiplex and eosinophilia, refractory bronchial asthma should make you think of Churg-Strauss syndrome or EGPA. Okay, so again, I'm completing the triangle of EGPA. The first part of the triad is refractory bronchial asthma, which means it is not responsive to steroid therapy. Number two is increased eosinophils, and number three is multisystemic involvement in the form of mononeuritis multiplex, and most common cause of death being the cardiac involvement. Most common cause of death being the cardiac involvement. Okay, let's now for a while. Also one more thing that I missed, that EGPA will have P-ANCA positivity, and P-ANCA, as Dr. Nazia Qureshi said for a while ago, it is against the anti-MPO antigen. Fantastic. So let's go to the next slide where we have the total systemic involvement. Let's go to the next slide, sir. The next slide. Yes, can you please zoom me this slide? Can you please zoom me this slide where I've written the systemic manifestations of eosinophilic? Yes, exactly. Yes, can this slide be zoomed? Yes, fantastic. So you can see the major thing that is associated with eosinophilic granulomatosis is the ear, nose, and throat manifestations. Again, predominant ENT manifestations, but mind it, even Wegener's had ENT manifestations without eosinophilia. EGPA has ENT manifestations with eosinophilia. So you have serous otitis media, you have allergic rhinitis, you may have nasal obstruction, you may have nasal polyps being formed. Can you take it a little down, sir? Yes, you see, you have asthma, the cardinal feature of EGPA. Yes, pulmonary. 90 to 100% of patients have pulmonary involvement in the form of refractory bronchial asthma. You may have hemorrhage or effusion, but I'm not focusing on that. I'm predominantly wanting to tell you major focus on refractory bronchial asthma. Let's forget lymphatic for a while. Let's go to renal. Yes, it can lead to proteinuria, that is glomerulonephritis will be there with microscopic hematuria and necrotizing glomerulonephritis. As I said, glomerulus means small vessels. Anytime small vessel of the glomerulus will be involved, glomerulonephritis will come in, proteinuria will come in, hematuria will come in. Okay, under the peripheral nervous system, you can see peripheral neuropathy, it can come. Under this, we have the most common involvement as mononeuritis multiplex. We have hepatic involvement as well. We have the CNS involvement as well. Some GI involvements here and there, but predominantly, as I said, it has to be a pulmonary involvement in the form of refractory asthma, renal involvement in the form of necrotizing glomerulonephritis and RBC casts and hematuria, and along with it, there should be eosinophilia that you find in the blood. Along with it, mononeuritis multiplex like features. You will have most common cause of death being the cardiac involvement that you find, and that sums up EGPA for us. The antibody is anti-P-ANCA, P-ANCA, and the antigen is anti-MPO. let's get back to the slides, sir. Let's get back to the slide. The earlier slide. Yeah. No. The first one. Yeah, exactly. Okay. Now, having done both these, we will come across something which is called the MPA. We'll come across something which is called the MPA. And what is MPA? Again, just like I had kept PMR out of that large vessel vasculitis list, so have I kept MPA outside, because it's something which mimics small vessel vasculitis very much, but just like PAN, we need to know some few no's. What are the 4 no's in MPA? So the first no in MPA is no ENT manifestations. No rhinitis, no nasal polyps, no rhinosinusitis, no strawberry gingiva, nothing of that sort. Number 2 no is no bronchial asthma. I'm repeating this. Okay, cardiac manifestations, a little detail. Okay, I will tell you about cardiac manifestations. Let me just finish the MPA topic, and I will talk to you about the cardiac manifestations that we have. Okay, so in MPA, you have 4 no's. The first no is ENT clinical features are not present. Bronchial asthma is not found. Eosinophilia is not found, and granulomas are not found. If you clearly see, all these 4 no's itself will help you distinguish from ANCA-associated vasculitis with MPA. In MPA, you had granulomas. I mean, in ANCA-associated vasculitis, you had granulomas. Here, you do not, which is why I wrote granulomas are found in ANCA-associated vasculitis except MPA. You have ENT clinical features in both Wegener's and Church-Strauss. Here, you do not. You have eosinophilia in Church-Strauss or EGPA. Here, you do not. And last but not the least is you have bronchial asthma and high eosinophils in EGPA. Here, you do not. So the 4 no's of PAN, the 4 no's of MPA will help you distinguish PAN from the other vasculitis and MPA from the other ANCA-associated vasculitis as well. Coming to the cardiac involvement, I think who asked me that question? Dr. Twinkle. So the cardiac involvement that you find in cases of ANCA-associated vasculitis, mainly EGPA, is number 1, you may find eosinophilic myocarditis which can develop, and that myocarditis is actually the cause of death. Okay, it's a histopathological finding, eosinophilic myocarditis, and that can lead to a cause of death, which is why the most common cause of death has been a cardiac involvement in EGPA. Okay, correct? Is that clear? Twinkle, any more questions regarding that? Twinkle? Okay, fantastic. Okay, so now we are done with the ANCA-associated vasculitis. The last topic that we have of the day is the immune complex mediated vasculitis. When I talk of immune complex mediated vasculitis, one thing that I clearly said, when I talked of small vessel, angio is normal. So diagnosis of choice is biopsy with immunofluorescence. Immunofluorescence negative, ANCA-associated, that is also called post-immune. Immunofluorescence positive is immune complex mediated. Correct. Now, when I talk of immune complex mediated vasculitis, I am predominantly meaning 2 things. One is cryoglobulinemia and one is henoch-Nolan purpura. Among this, cryo has a variable presentation. It can come in any age, just like any other ANCA-associated vasculitis. But henoch-Nolan purpura predominantly comes between the age of 6 to 20 years old. Very rarely in India have I found out cases beyond 20 years. In fact, one of my friend's sister has had a case of henoch-Nolan at the age of 21 or 22, but all of them are a typical HSP. Typical HSP rarely occurs after 20. In India, the age group is around 9 to 20 years of age. Okay. Now, just like any other small vessel vasculitis, it will have a palpable purpura. It will have polyneuropathy. It will have some GI manifestations. But what is specific in terms of HSP are 3 things. When I talk of HSP, there are 3 things. Number 1 is arthralgia. What is the meaning of arthralgia and how is it different from arthritis? Arthritis means inflammation of the joint. Arthralgia means there is a pain in the joint. Simple. A pain in the joint without inflammation, arthralgia. Pain in joint with inflammation, arthritis. So arthralgia is found in HSP. So the triangle of HSP that you are seeing, the first part of the triad is arthralgia, and it is not arthritis. Mind it, these patients, usually kids, they will complain to you with non-specific joint pain in their body, and it is not going to be erosive. It is not going to be inflammatory. That will distinguish it from arthritis. The second thing that you will have is GI manifestations. So what are the GI manifestations that you have in HSP? It is pain abdomen. You can have a bleeding, At times, very rarely, you can have a very serious presentation in the form of intersusception. Intersusception means severe pain in the abdomen with passage of black, red, current jelly stools, red jelly stools due to obstruction in the intestine, causing intestinal obstruction. That may be a very rare but a very severe manifestation of HSP. But otherwise, pain, bleeding, and diarrhea are something which are very common GI involvement in HSP. The third one is a palpable purpura. As I said, any immune complex small mediated small vessel vasculitis will have a palpable purpura, and this palpable purpura, I repeat for the 100th time probably, is not associated with thrombocytopenia. Platelet count is normal in HSP, normal. The palpable purpura is usually seen on the lower limb and the buttock regions on the extensor surfaces. You will usually have a lower limb predominant purpura. You'll have a palpable purpura with normal platelet count, lower limb involved, buttocks regions are involved. And on biopsy, there's something which I want you to write. On biopsy, you will find something which is called a leukocytoclastic vasculitis. Leuko means WBCs. Leukocyte means WBCs. Clastic means breakage of WBCs. Vasculitis means inflammation of the blood vessels. But let me tell you, leukocytoclastic vasculitis is not specific for HSP. It can be found in any small vessel vasculitis. So why did I talk of this? I talked of biopsy because in HSP, we do biopsy to diagnose the lesions. And on biopsy, one thing that we find is leukocytoclastic vasculitis, which is not specific. But what is specific in the biopsy for HSP is the IgA, immunoglobulin A deposits that are found in the dermal papillae. So if you can clearly see, I don't know if this slide can be zoomed in. If this slide can be zoomed in, if you will find that near this HSP triangle, you will find that this green autofluorescence. Yes, if can this slide be zoomed in? Can this slide be zoomed in? Yeah, a little. No, not this, not this. Yes, can you take me a little to the right? To the right. Take me a little to the right. Yes. Yes. Zoom me this HSP wala triangle. Please zoom me this HSP wala triangle. Yes. And that the figure that is there in the corner. Yes, that's the box that I want to zoom in. Can I zoom in any further? Can I zoom in any further to this? I don't think that it can be zoomed any further.
No,
but
I can't. This is the maximum.
Yeah. So one thing that we find, yes, it is fibrinoid necrosis with IgA complexes in the basement membrane. No, it is not in the basement membrane, dear. It's not in the basement membrane, Dr. Nazia. It is below the dermis that we find. So the basement membrane is the dermoepidermal junction, like the dermis and the epidermis. So epidermis is above, dermis is below, and this junction is the dermoepidermal junction. That's the basement membrane that you're talking of. But if I go below that, in the dermis, you will have IgA positive depositions, which are basically the autofluorescence that is found in small vessels. So I'll try to make these images a little bigger from the next time, but then in the laptop, or there's only a certain amount that you can resolute and make it big. You cannot make it bigger after that. So that is perfect. Let's get back to the original size of the slide. So as I said, in HSP you have a triad of three things. Number one is a non-erosive, a non-inflammatory kind of joint pain, which is arthralgia. You have GI manifestations in the form of pain abdomen. You can have bleeding. Diarrhea is also there, but most severely, very rarely found, but very severe cases of intersusception have been reported. And the last thing that we can say is it can have a palpable purpura. And when I have these palpable purpura, I will take a biopsy exactly from these skin lesions. If you remember, we saw a picture in that image palette where we showed purpura. These purpuras are predominantly in the lower limb and the buttock regions. You take a biopsy from one of those lesions. One thing that you will find is leukocytoclastic vasculitis, which means the WBCs are being broken in the blood vessels, but that is not specific. What is specific is IgA, immunoglobulin A predominant deposits below the dermis that is found. So that completes HSP. The treatment of HSP is again very supportive, but in some cases wherein you have severe bleeding from abdomen, you have severe intersusception, severe abdominal pain, you have probably you will have to give corticosteroids and immunosuppression. Okay, one thing that I continuously told you in small vessel vasculitis, it will involve the pulmonary renal system in small vessel vasculitis. Pulmonary involvement is very rare in HSP, but renal involvement is there. It can come with glomerulonephritis. And what is the type of glomerulonephritis that we find? We'll find the C3 levels being normal. Again, I repeat, when I talk of complement levels being normal complement levels, if I talk of in any glomerulonephritis, I either predominantly mean a PSGN or I mean an HSP. In PSGN, initially they will be low, but then they'll come back to normal and only the kidneys will be involved. But in HSP, every other system will be involved. C3 will be normal. I repeat again what I'm saying. When I talk of glomerulonephritis with a complement level normal complement levels in a glomerulonephritis, there are only two conditions. One is PSGN, post-streptococcal glomerulonephritis. The other is HSP. Post-streptococcal glomerulonephritis, you only have kidney involvement. You do not have other systems involved. Here, as you can see, GI involvement, joint involvement, kidney involvement, multi-system involvement is there with C3 normal. So C3 normal, always think of PSGN, always think of HSP. So that completes HSP for us. I have also talked to you about the treatment. Let's come to cryo. I talked of the two hepatitis things that I talked to, pan khata bacha, pan and hep B, and C for cryo and C for hep C. So hep C involvement is very much positive. There's somebody was asking me a few minutes back about rheumatoid vasculitis. This is one of them. Rheumatoid factor RF is positive in cryo. So cryo, when I talk of hep C positive, RF positive, very, very, very important. I think that was Dr. Bilal, if I'm not very wrong. So cryo involvement is with hep C. It is with rheumatoid factor positivity. And the way you differentiate it, how do you differentiate it from HSP? Number one is in HSP, you had IgA deposits. Here you have IgG deposits. Immunoglobulin G deposits are positive in cryo. Immunoglobulin A deposits are positive in HSP. Is that clear? Is that clear? Everyone clear? Anti-CCP was also positive with RA. Yes, anti-CCP is the most specific thing. So when I talk of rheumatoid arthritis, rheumatoid factor positivity is there, but anti-CCP is a more specific test. Fantastic. Rheumatoid arthritis is something that I am not going to cover here because I'm only going to talk of vasculitis today. I will surely keep I'll surely keep RA as one of the other topics in the upcoming webinars. We can talk of RA and SLE, but then if I start talking of RA, it will take me to a completely different area. Okay, but I'll just give you a little. I won't disappoint you. That's something which I always believe in, to give something. So there's a very common way that we often get, misdiagnosed or confused about OA, that is osteoarthritis of the hand, and RA of the hand. Osteoarthritis of the hand, OA, versus RA, rheumatoid arthritis of the hand. I'll just give you a little trick so that you become happy, and I also am happy that I do not have to shift to RA. So one thing, how do you diagnose whether it's an OA of the hand or an RA of the hand? I want you all to look at the screen and say OA, OA. That's how you call someone, right? OA. So when you say OA, the fingers, the joints which are pointing towards that person, because I'm looking at you and saying, so Dr. Bilal, I'm saying OA. When I'm saying OA, the joints that are pointing towards you are the ones that are involved. So the distal interphalangeal joint, the proximal interphalangeal joint, and the metacarpophalangeal joints. These are the joints towards you involved in OA of the hand. When I say RA means I'm calling it towards me. The wrist is involved, the thumb is involved, and the MCP is involved. So wrist is involved in RA, thumb involved in RA, MCP involved in RA, OA, proximal and distal interphalangeal joints involved in OA. That's the only little thing that I'll tell you. I won't talk of RA right now. The only reason I told this is so that you are also happy receiving something which is interesting. Because in my MBBS days, I used to always think both involve the hand. How is OA different from RA in the hand? So that's something I can just tell you. But RA, I'll never be able to take up today, because RA, if I start discussing RA, it will take me 1.5 hours again. So I'm not going to shift to RA today. In vasculitis, rheumatoid arthritis, vasculitis, and everything, we'll take up when I talk of RA again. So let's come to the image section. Let's come to the image palette. Thank you so much, Dr. Mahmudal. Thank you. Let's come to the image palette. Yes, we just have 2 or 3 images remaining. So yes, I will now talk to you about this disease called Behçet's disease. Can you see Behçet's? Yes, Behçet's disease. Yes. So when I talk of Behçet's disease, there's something that I really want you to write down. So Behçet's disease is something which falls under small vessel vasculitis, but does not fall in that chart. The reason being, it has some atypical presentations. Behçet is very common in India. Trust me, Behçet is very common in India. So in Behçet, there's one essential criteria. The essential criteria of Behçet is you have to have oral aphthous ulcers. Oral ulcers, which will be extremely painful ulcers. There'll be recurrent oral painful ulcers. That should be an essential criteria. Without oral ulcers, you can never diagnose Behçet's. Okay. Along with this essential criteria, you can have other involvements, like you can have a genital involvement in the form of, in males, you have scrotal ulcers, which are very painful, or you can have ulcers on the shaft of the penis, or you can have ulcers on the glands. Can sir point me towards this tongue and oral ulcers that you have? Move your cursor towards the tongue and the oral ulcers that are shown under Bessett's. Can someone make me that? Can someone show me with that pointer? Yeah, no, just the image below it, just the image below it. Yes, so that's the oral ulcers that you find. So these are typical oral ulcers. If you can see, I don't know if it's visible to you, on the lips you are having fissured ulcers which are there on the lips, on the tongue. So these are very painful oral ulcers that are found, recurrent painful oral ulcers. That's an essential criteria of Bessett's diagnosis. Along with the next images of the penis, where you have the ulcers which are there on the shaft of the penis. Predominantly, it can be there on the scrotum as well, on the glans penis as well. In fact, here it is involving the glans penis. So that's the second criteria. The third criteria is, which is the first image in Bessett's. That first image, I know, above the tongue wala image that sir pointed. Yes, that is what we call as a pathology test. That is a okay. So Dr. Twinkle says that's very common presentation in immunocompromised. Yes, oral ulcers is very common in immunocompromised. But how you will differentiate is in oral ulcers of those things and Bessett's. I'm coming to you here. So as I said, mandatory is oral ulcers. Along with it, you will have genital ulcers. Along with it, you will have pathology test positive. This is how you will distinguish in the immunocompromised oral ulcers versus these patients of Bessett's. So what is pathology test positive? Suppose you and I take this pen, and this is the blunt end of the pen. If you can see, this is the blunt end of the pen, and I do this. Do you think I'll develop a rash? Is there any chance that I'll develop a rash on my face if I just do this with the blunt end? No, right? But in these patients, you will have the development of pruritic, itchy, rash-like lesions with non-traumatic skin pricks. Non-traumatic. This is not the sharp end. This is the blunt end. If you can see, the non-traumatic skin pricks will lead to pruritic, palpable purpuric-like lesions. You will find exactly what you're seeing on the back of this patient. Red lesions on non-traumatic prick. That is what is a pathology test positive. It is found in almost 40 to 45 patients of Bessett's will have pathology test positive. So this is the third involvement. What is the first involvement? I said oral ulcers, recurrent, painful. That's the aphthous ulcers. It's an essential criteria. Without oral aphthous ulcers, you can never talk of Bessett's. Second is genital ulcers in males, mainly scrotum. In your apart from scrotum, you can find it on the glans penis. You can have it on the shaft of the penis. In females, you can have it on the labia. Third criteria was a pathology test positive, which is non-traumatic skin pricks leading to purpuric skin rashes. The fourth thing is skin involvement in Bessett's. The skin involvement can either be, vesicobulous lesions. You can find, you can find pruritic lesions. You can find acne-like lesions. But along with it is an eye involvement as well. You will find a redness of the eye, which is called uveitis, and most commonly you find posterior uveitis. On all the other rheumatological conditions, predominantly you have anterior uveitis. One of the basic rheumatological conditions where you have a posterior uveitis is Bessett's. Always you should think, whenever you're seeing a posterior uveitis, always think of Bessett's in mind. If that patient is also having oral ulcers, you should always investigate in lines of Bessett's. One HLA type, HLA antigen, which has been associated with Bessett's, and I want you to write this, is HLA B7 and B51. B7 and B51 are the two HLAs which have been associated with Bessett's. So I'm repeating Bessett's. There are 5 things. One is essential criteria for Bessett's is oral, recurrent, painful oral ulcers. Second thing is genital ulcers. In males, it's on the scrotum, shaft of penis, or the glans penis. In the females, it's on the labia. The third criteria is the pathology test positive, which is found in almost 40% patients, where a non-traumatic skin prick can lead to pruritic lesions, red pruritic lesions. Number 4 is what you have as, the eye involvement in the form of posterior uveitis. It can also even lead to retinal involvement and cause blindness, for that matter. It can lead to retinal involvement and cause blindness as well, but posterior uveitis is more common. And number 5 is the skin lesions that you find, where you can find vesicobulous lesions, you can find scarring lesions, you can find acne-like lesions. But oral ulcers is a must criteria. Apart from oral ulcers, if the other out of the other 4, even if 2 are positive, it makes it a case of Behçet's. Yani ki 3 out of 5 should be positive. 3 out of 5 should be positive. With oral ulcers, definitely should be positive. That makes it a case of Behçet's disease. You have 2 homeworks. That's something which I'll expect. Number 1 is, what is the most common cause of vasculitis? The most common vasculitis in India. Somebody had asked me earlier. I had not answered this question for a reason. I'll tell you this answer. The most common vasculitis that we have in India is an isolated cutaneous small vessel vasculitis. Isolated cutaneous small vessel vasculitis. It just comes, stays for a while, it goes away on its own. Mostly found on the lower limb, which is why in kids mostly they are wrongly diagnosed as HSP, because initially they look very much like a palpable purpura of the lower limb and the buttocks. Later they become fine with time and it looks like an HSP initially, but it is not an HSP. It is isolated cutaneous small vessel vasculitis. The homework that you have is, can drugs cause vasculitis? Can drugs cause vasculitis? If yes, what are the drugs that cause vasculitis? That is the one homework from me. The other homework that you have is, there's one image that we did not cover, and it's a reason that I did not cover. That is Kawasaki's disease. I will talk of Kawasaki, but it's for you to fill up that mnemonic of febrile. So when I talk of Kawasaki, it is a medium vessel vasculitis found in children, and the must criteria is fever for more than equal to 5 days. More than equal to 5 days in a child, undiagnosed fever, no tests coming positive to find out the cause of fever should make me think about Kawasaki. And when I talk of Kawasaki, fever more than 5 days is a mandatory criteria. Fever that is not responding to antibiotics. Why it is not responding to antibiotics is because it is not an infectious cause. It's a vasculitic cause, which is why that fever will never respond to antibiotics. Next that you find in Kawasaki is, you can see the eyes. You can find that bilateral non-purulent conjunctivitis. Non-purulent conjunctivitis. First, penicillin. Yes, penicillin can cause vasculitis. I'm not taking this up right now. This is a homework for all of you. What are the drugs that can cause vasculitis? And I want you all to note that down in your respective notes. So that's your homework. When I talk of Kawasaki, if you can see the eyes, you can see the eyes of that kid. It is having red colored, so it's a bilateral conjunctivitis, but please note it is a non-purulent conjunctivitis. There is no pus in that conjunctivitis. It's a sterile conjunctivitis. The other things that you can have, you can see the child is having a swelling here. Yes, that's the cervical lymphadenopathy that you have. And you can also have a rash. You can see the back of the child. There's certain rash that you find in this child's back. Yes, so that's a desquamative rash. Again, repeating this, it's for you to complete that mnemonic, but I'll say the disease. Fever for more than 5 days, along with a rash that is found, which is the desquamative rash, cervical lymphadenopathy palpable, bilateral conjunctivitis, which is non-purulent. That's the most important word. It's a non-purulent. There is no pus in that conjunctivitis. It's a sterile conjunctivitis. And apart from that, you have the most fatal thing that can develop, which is this image. Can sir please zoom into this image, which is to the left of this person smiling? Yes. Yes. Just to the left of that. Just to the left of that person smiling. No. Just down. Bring it down. Yes, to the left. Please move to the left. Yes, that image. Yes, that image. No, not this. Just the one left to it. The one left to it. No, sir, you're moving to the right. You're moving to the right, sir. The one to the left. Extreme left. The extreme left image.
Yeah, which image precisely? The tongue image?
No, sir. The first image of that line. The first image of that line.
This
yes. No, the one below. The one below it. The one below it.
This one?
The one below it. The one below. Yes. That is the image. So this is the most fatal complication that you have of Kawasaki. You can see there's an abnormal dilatation of the coronary arteries that is called coronary artery aneurysms. This can happen after 2 weeks of Kawasaki, which is why we will never wait to do an angiogram to check whether Kawasaki has progressed to aneurysms, right? You won't wait. You won't keep a child in fever for 2 weeks to die, right? So although Kawasaki coronary aneurysms are very specific, but they are usually late presentation. More than 2 weeks is found. And because of this, we find that most kids die. If Kawasaki patients are having aneurysms, it's a very, very bad prognosis. The treatment is very high dose of aspirin and immunoglobulins. That is all that we have as a treatment for Kawasaki. Somebody has asked me, can you tell me a little details about Steven-Johnson? Okay, Steven-Johnson is a drug reaction. It's not related to vasculitis, Dr. Twinkle. Steven-Johnson is an adverse drug reaction that can happen due to the hypersensitivity to certain drugs. Amoxicillin clavulanic acid is a drug that can cause Steven-Johnson's. It's a very rare phenomenon, but it can come with a variety of drugs. Sulfonamide kind of drugs can cause Steven-Johnson. It's a type of skin reaction that we have as an adverse reaction to drugs. It's not anything related to vasculitis. It looks like purpura. I can understand why you asked me, but it's not purpura. Trust me, if you see the images in Google also, you can clearly see that there's a difference in palpable purpura versus the rash of Steven-Johnson syndrome. So that completes my presentation today on vasculitis. And there's one question that I've kept in the end. There's one question that I've kept in the end. It's one question. Can sir take me to that question? The last slide. The last slide. Yes. So the question that I asked, and something that I've already told you, is what is required for the diagnosis of Behçet's. You can find a pathology test, yes. You can find posterior uveitis, yes. You can find genital ulceration, yes. But no diagnosis of Behçet is without recurrent oral ulceration. So that is the answer to that question. You will never can you diagnose Behçet's without a recurrent oral aphthous ulcers. You can find genital ulcers, you can find eye involvement, that's perfect. But without oral ulcers, without recurrent aphthous oral ulcers, you cannot be diagnosing Behçet's. So that kind of takes me, just give me a moment. So that kind of takes me towards the end of my presentation. I hope you have enjoyed this presentation, and I hope I could cater to you all. Kawasaki affects children, always children. Kawasaki's children. Neurological manifestation in Behçet's is common. Yes, neurological manifestation is common. Who has asked me this question? Who has asked me this question? Dr. Nazia. Fantastic. Dr. Nazia, I'm so impressed with the way you have asked me certain questions. Okay. So answering this, neurological manifestation in Behçet's is common. Yes, it is common. And usually it involves the brainstem. And if you ask me brainstem, it involves mainly the midbrain. Mainly the midbrain is what is involved. So it's a brainstem involvement that you find in Behçet's. Yes, neuro Behçet's is possible. Thank you. Thank you so much, Dr. Abhishek. Dr. Kirti, thank you. Thank you so much, Dr. Lovepreet. A big thank you to everyone. Yes, diclofenac for Steven-Johnson's. Yes, that's perfectly correct. Thank you. Thank you so much. I am waiting to have your feedback, and
Yes,
I'm waiting for your questions. And I'm really glad that, it's been, I'm very happy with the response that I've got from all of you today. Really glad. Thank you, Dr. Pratibha. Dr. Agha, thank you. Thank you. Sure, Dr. Nazia. I think it's on the 20th that we have another session on approach to respiratory failure. No, I think it's approach to glomerulonephritis. So from the ones who have done today's session and have certain doubts about glomerulonephritis, we will have a very detailed flowchart based discussion on that day about glomerulonephritis. That's something which I can promise you. So that will be a related, which is why I've kept related topics. If I take vasculitis, I talk of glomerulonephritis. I also talk of glomerulonephritis in the next class. So now on 20th, I'm having a session. I think Ifka and the team will update you about the details of that. But yes, I'm looking forward to having such sessions with all of you. It's been an absolute pleasure. Thank you so much, Dr. Mahalakshmi. Thank you so much. It means so much. I mean, the way that you have been responding, the way that you have been, keeping up with the pace that I have been telling things. It really means a lot with me. And the questions that you've asked, particularly all of you, the way that you've answered, I'm really impressed. Thank you so much. Is there any questions that I can have from your end? Anything that you want to ask me regarding
yes,
today's topic?
yeah. Thank you, doctor. Thank you so much. The session was so informative. I might, doctors, you can ask questions. I know for doctors in between picked all your questions and explained it in depth. I do believe you still have doubts at the back of your mind. We invite you to all to post your questions on the chat box. We will read it out to you, and doctor will answer to it.
Absolutely, sir.
So Rubina says, great presentation, sir. Thank you, Dr. Rubina. Charumati says, thank you so much. Sushti says, thank you, sir. Thank you.
Thank you so much. Thank you so much to everyone. Thank you.
Great. Yeah. Looks like we have no questions.
Yeah, because I
Ajay
think I've taken
Vishwakarma
most of the questions during the
says,
session
thank you
itself.
so.
Okay, may I know why Takayasu
Yes, I know.
arthritis is more fatal, is most fatal in vasculitis? Yes, it is because of the development of coronary aneurysms. It is because of the development of coronary aneurysms. That is why, who's this Dr. Aga? So Dr. Aga, what happens is vasculitis, I mean, once Takayasu, okay, is it Takayasu or Kawasaki? What? Okay, Takayasu. Takayasu, you're talking of most fatal in vasculitis. Most fatal vasculitis that you have is Takayasu because of the occlusion of the subclavian vessels, number one. Number one. Number two is you have good amount of mortality, but trust me, it's not the most fatal. The most fatal, if you ask me, it's Kawasaki. I mean, Kawasaki, if it's not diagnosed on time, if you're not giving high dose aspirin on time, it's very difficult to save those kids. Because once aneurysms develop, it's really difficult to save those kids. Takayasu is not really very fatal. I mean, I've seen patients of Takayasu surviving till 65, 70. Aram se.
Thank you, Lord. Thanks for answering that.
You.
Uh, any Kawasaki cases in adults in your experience?
Yes, Kawasaki adults, no. So I'll tell you one thing. Again, Dr. Aga, in adults now, we don't call it Kawasaki. We call it MISC, MISC. You can read about it. Multi-inflammatory systemic conditions. So it is a case of immune reconstitution. You can call it as a case of HLH, if you know, macrophage activation syndrome. So all of that comes under MISC. Kawasaki is a separate name, which was only, so see, Kawasaki, the Japanese scientist, had given that disease only, he had seen this only in children. So the adult counterpart of Kawasaki, we call it MISC. The features are almost the same. Aneurysms are also found there, but we don't call it Kawasaki in adults. We call it MISC, MISC. You can read about MISC.
Great. So, great, doctor. Just a small
Yes,
announcement.
yes. MISC. Just a minute. MISC is an umbrella term having many in under it. Absolutely, absolutely, absolutely. I don't disagree to you. But then that is why I said Kawasaki as a special entity is only named for the children. Kawasaki in adults very rare, very rare. I have not seen a Kawasaki in adult yet. Kawasaki in children is what we have read about. MISC, we have seen a lot of cases of MISC. Yeah, we have seen MISC. In fact, I mean, just although it's a bit personal, but then the case that I've been talking about, of my family being admitted in the ICU, it's a case of MISC itself. So, like MISC is something which we have seen. I'm actually myself treating a case of MISC at this point of time, but yeah, Kawasaki is something which we see in adults mainly.
Great.
Yeah.
Yeah.
Yes, sir. So was saying something. Yeah.
Yeah. A quick announcement. We will be sharing the link to register for the certificates. So please do fill the form. Also, rate us on Google. Uh, the link will be provided on the form. So please rate us on Google that now and also upload the screenshots of the review we gave in the form, and you will get your screen certificates by tomorrow EOD. Please bear with us. I have pasted the certification registration form for today's webinar in the chat box. Please head out to the link, answer you can fill all the information. Also, please rate us on Google. These ratings will push us to more such webinars. The main goal of this webinar is to reach out to all the doctor community to answer all their questions with the experts like Dr. Navonil, Dr. Alan G, which happens to be attend our session today. He is one of our national director. He will be busy also, but he also attended. Dr. Navonil, Dr. Navonil, I would extend my heartfelt thanks to you because we know the situation what you are going through, and you made yourself. Oh, okay. One second. Uh, I think you unmuted yourself. One second, doctor. Sorry. Yeah, you can talk now. Yeah, thank you so much because given your situation, today you told us that no, I have committed, and well, let us not postpone it.
Yeah.
Thank you for that sportiveness and your
Thank you.
dedication towards learning and
Thank
people
you.
enabling to learn such big session. Thank you
Thank
so
you.
much.
Thank you
And
so much. Thank you.
yeah, doctors, I would request you to follow our social media links to know more such webinars, because you might already know we are coming up with lot of stuff to help you guys. We are launching e-learning portal where you can attend these webinars and earn instant certificates. We are creating forums where you can also, Dr. Navonil will answer your questions. We have a committee of doctors where we answer all your questions in the forum, not just webinar. People certain Sometimes what happens, these webinars will be your window to ask your questions to the experts, but we are extending that window to called forums, where you can connect with all our experts. No cost in There is no hidden cost to this. This is completely free to our doctors, to everyone. It is easy accessible. It is completely free for everyone, where you can earn certificates. You can get all your doubts cleared through our forum. We are launching. It will be very soon out, in 15 to 20 days time. So please look out on our social media channels. Also, I am posting our WhatsApp channel link. Please follow all our social media channels, where you will get all the latest updates on what Mediversal Academy is doing in order to educating doctors in India. Thank you so much. We're also coming up with two more courses. Just a quick brief here. I'll not take much of time here. We are launching with AI in healthcare. It's a comprehensive course where artificial intelligence helps doctors in a daily basis. We are also having new where the topic is chat GPT for healthcare professionals. It's a pure technical chat GPT prompt session, where our IM alumni Mr. S. Subramania will teach you guys to the depth how to use chat GPT, how to use it, everything. So look out for it, and please do fill your form to get the certificates. Before I end, I want to edit in a very formal note. Though it might sound like a formal, but it's not formal. Doctor, thank you so much for the insightful session. I personally learned a great deal, and I'm
Thank you.
sure
Thank
all
you
the
so
doctors
much.
here would agree with me. On behalf of everyone, I extend sincere gratitude to Dr. Navonil. It is the kind of the engagement and participation that motivate us to organize more such webinars in the future.
Thank
Thank
you.
you all
Thank
for
you.
joining us today. We hope you
Thank you
found
so
this
much.
webinar informative and valuable.
Thank you so much.
Yes,
Regards
if
to
you
all.
have any further questions, yeah, any questions, please reach out to us through our social media channels. We will be there to assist you. And thank you so much. Have a great day.
Thank you. Thank you, everyone. Good night. Good night. Thank you.
Good night. Yeah, I am ending the meeting to all, doctor. Thank you so much. Thank you for
Yeah,
joining.
sure. Sure. Thank you. Thank you
Yeah.
so much. Yeah.